Sepsis is caused by polymicrobial pathogens, including aerobes, gram-positive and negative, gram-variable Gardnerella vaginalis, anaerobes, and others like chlamydia or ureaplasma. Risk factors include prolonged labor, prolonged rupture of membranes, cesarean section, chorioamnionitis, and many vaginal exams. And particularly prevalent risk factors in developing countries are delivery by untrained birth attendants, unhygienic conditions, lack of access to adequate health care, delays in reaching health facilities, also anemia and malnutrition, and of course HIV/AIDS. Okay, it doesn't show my full figure. Let's see if it'll show up on the next one. Oh, it does, okay. This slide shows, it's a meta-analysis of the timing of maternal deaths relative to labor and delivery. And as we all know, the vast majority occur in the first 24 hours of the delivery. Hemorrhage is the most frequent cause, and the vast majority of those deaths occur within 24 to 48 hours. And one study at least showed actually the majority of their deaths occurred within 4 hours. So it's a very acute and sudden complication. Preeclampsia also occurs around the time of labor and delivery and extends onwards a little further than hemorrhage as far as risk of death goes postpartum. Whereas in contrast, sepsis is very different. Sepsis deaths tend to not occur before 2 days postpartum or even 3 days postpartum. The peak is around 5 to 7 days postpartum, and modeling has shown that it can occur even up to 42 days postpartum. And that arrow doesn't really express as well that the risk does decline as you go later, but it is different from preeclampsia and hemorrhage in that the deaths occur after a woman is home, even if she has delivered in facility. So postpartum care, postnatal care visits in the community are a very important intervention for this, which we really haven't addressed that well in the maternal health world. So let's move on to prevention and management. By the way, this picture's from Badakhshan, Afghanistan, and this shows 4 men carrying in a stretcher, and the woman was having a complication in pregnancy. And they brought her from some distant village, and she did survive. So at the facility level, it's more straightforward, reducing the length of labor, reducing the time of the rupture of membranes, reducing the number of vaginal exams, which also includes use of the partograph, treatment for PROM, and infection prevention. And now I'm going to just show you a little bit of data from the quality of care surveys. They've only been done in African countries so far, and I think that we at MCHIP are interested in doing some studies in Asian countries. If people are interested, we could talk about that. So this data shows from 7 African countries and the availability of infection prevention supplies in the delivery room. And I can't quite read those numbers from here, but they're not bad. They're over or around 90%, except for soap and water being present, which was surprising to me. This one is a little more important to look at. This shows the quality of infection prevention practices, so what the healthcare providers actually do in the labor and delivery room. And some things were very high, like disposal of sharps and, let's see, again, I can't read it very well, sorry. But what's the more important finding is that hand washing is only around 37 or 38% before examining a woman or afterwards, which is quite shocking considering this doesn't require technology. A bar of soap certainly is not an expensive thing. I realize in some facilities there may be limitations with clean running water, but hand washing is a basic thing that every healthcare provider can do. And this slide, the last one from the Quality of Care Survey data, shows the availability of supplies to manage sepsis once it's occurred. And you can see that antibiotics that are needed for the treatment, which include ampicillin, gentamicin, and also flagyl, we don't have on there, metronidazole. But the first two are only available around 50% of the time, although syringes and Ringer's lactate is available. But essentially the antibiotics weren't readily available in most of the facilities that we were in these 7 countries. Management of infection to date, the gold standard is based on WHO's MCPC manual, which is, you can see in a screenshot on the right or left side of the screen. And so the treatment is ampicillin, gentamicin, and metronidazole. They're all IV drugs done at various times of the day. And so it's by necessity, a facility-based treatment. Therefore, women who are at home must get to a facility for treatment. And with the high case fatality rate, you can probably see what the implications of that are already. Okay, so moving on to community level, some of the issues, reducing maternal mortality due to sepsis in South Asia is hampered by the large proportion of births that occur outside the formal health sector. About 41% only are attended by a skilled birth attendant in South Asia. It's only 14% in Bangladesh, 11% in rural areas where 80% of the births occur. And even where deliveries take place in facilities, as I mentioned earlier, the majority of women are home within 24 to 48 hours of delivery before the time when sepsis complications begin to present themselves and the risk of death increases. There's been some interventions at community level that have shown good success and should definitely be either considered for more research or even program implementation, depending on the strength of the evidence. So training birth attendants or arming them with clean birth kits was associated with reduced infection and maternal mortality in Pakistan, Egypt, and Tanzania. So for example, in Pakistan, the odds of sepsis were reduced in the training intervention group by 83% compared to the control group. There was a non-significant reduction in maternal mortality. Also, women who used clean delivery kits were 3 times less likely to develop sepsis than women who did not in Tanzania. Cleansing of the vaginal canal with chlorhexidine is showing promise. In Malawi, a study that used 0.25% chlorhexidine, infection rates were also decreased. And also, nutritional micronutrient support is also important. As far as identification and management, women's groups in Nepal's reported increased care seeking for maternal illness. They use clean birth kits more and hand washing. And this was associated with a lower maternal mortality rate, although the cause-specific mortality was not reported. So where do we go next? As far as facility-based births go, consistently we're seeing issues with quality of care. And we need to find out why is that going on. We need to go to the providers and the people in the public health sector and ask them what are the barriers, and even if the supplies are there, why are they not using them? I know there's been some work done on this, but so far we don't seem to be addressing it consistently. And I think Anna Langer is going to be talking about quality of care later as well. Some innovative work that's going on are biomarkers to identify whether an infection may be coming on. And we need more work in the community, particularly population-based studies. So I'm going to tell you just for a minute about, there's a study being implemented here in Bangladesh and in 2 sites in Pakistan and in India if we can find an appropriate site. It's called the ANISA study, which stands for Etiology of Neonatal Infection in South Asia. Dr. Samir Saha of the Child and Health Research Foundation in Shishu Hospital is the PI of this. And it's to determine the incidence of etiology of community-acquired neonatal infections and the antibiotic-resistant patterns of them using community-based surveillance and laboratory methods. This is funded by the Gates Foundation, and they have also recently given us a generous grant to add a supplemental study to utilize the community-based surveillance where women who are pregnant are monitored to delivery, and then the newborns are visited, to now also include visiting and assessing the mother. We are going to develop a community-based presumptive clinical diagnostic algorithm for use by either low literacy or non-literate community health workers, refer them for treatment, the women for treatment, and also we'll be collecting data on the incidence and risk factors. This will be the largest population-based community research study to date that will provide these data. As I said, the women will be referred for treatment, and if they agree, consent, then samples will be taken to better understand the pathology and to identify as well the antibiotic sensitivity so that we can inform possible antibiotic regimens that could be used in a community setting. For example, say if they could get IM injection of gentamicin and then oral broad-spectrum antibiotics, which then is trying to reach all those women who don't reach facility. This will be starting very soon. We have a large sample size, almost a million population and 26,000 births. We're starting basically now, and pregnancy surveillance in November, and we'll be finishing around, sorry, that should say July 2014. Thank you.